Hello everyone, I am Dr. Noel Nalin Kumar, a pediatric orthopedic surgeon from the Hosmat Hospitals, group of hospitals, Bangalore. So today afternoon I'll be speaking about orthopedic well-being in children. I'll be touching on certain very common topics like vitamin D deficiency in children, injuries, especially fractures in children, and flat foot. And if time permits, one or two other common deformities which we encounter in children. Now, vitamin D deficiency, also vitamin D is known as the sunshine vitamin. The normal levels of vitamin D in children are anywhere between 30 to 100 nanomoles per liter. The deficiency state is a condition known as rickets in children, and the same deficiency in adults is known by a name called osteomalacia. Now, why is this called a sunshine vitamin? Is because the primary source, primary way we receive vitamin D is through exposure to sunlight. When our body gets exposed to sunlight, our a molecule, the cholesterol molecule in our skin gets converted into an inactive form of vitamin D, and which further gets processed and gets converted into active form of vitamin D. Now, the sunlight which we need to get exposed to for the maximum benefits is between 10 a.m. to 3 p.m. This time is the best where the ultraviolet B rays in the wavelengths of 280 to 350 nanometers are there, which help the maximum production of vitamin D in our body. Apart from sunlight, the natural sources of vitamin D are fatty fish, liver, milk, eggs. Normal daily requirement of vitamin D in a child about 1 to 3 years is 400 international units, and in children above 4 years and adults it's about 400 to 600 international units. In adults it is 600, and adults more than 70 years have a higher requirement up to 800 international units per day. Now, this vitamin which is produced under the skin, and also the vitamin which is in which we intake, is an inactive form of vitamin D. This has to undergo process in the liver and as well as the kidney for it to get to the activated form of vitamin D. So not only the skin, the liver and the kidney do play a very important role in the metabolism of vitamin D. And talking about vitamin D, it is not just a vitamin. Recent studies have emphasized the importance of vitamin D in heart health and also immunity, in immunity, developing adequate immunity. So it's more of a hormone. It functions like a hormone rather than just a vitamin. Now, when we talk about vitamin D deficiency rickets, the most common problem we see in children is bow legs. So, why bow legs is the bones soften and then they are not able to take the load of the child, weight of the child, and they start bending. The most common type of bend which we see in children is bow legs, or technically known as medical term is known as genu varum. Uh, Again, coming back to sunlight exposure, why in spite of India being having enough sunlight, India being India, we have enough sunlight, but still most of the kids, if we do get tested, and even adults, they turn out to be vitamin D insufficient or deficient. The reasons being, we don't go out in the sun enough. Even when we go out, not enough of our body is uncovered. We are wearing full length short, full length trousers and uh, shirts, so that our most of the body is covered, and we don't go out enough in the sun. And even if you go out, we go out in the mornings or in the evenings where the vitamin D production is not enough or adequate. Dark skinned individuals also take much more time than usual for the same amount of vitamin D production as compared to the lighter skinned individuals. Sunscreen reduces vitamin D production in the sun in the skin. This is because it blocks all kinds of ultraviolet rays. And so, my recommendation would be, if you are going out in the sun for a longer duration, say for 20, 30, 40 minutes, uh, more than that, 20, 30, 40 minutes, then apply sunscreen. If less than 40 minutes, less than 30 minutes exposure is expected, then you can go out without a sunscreen. And there are, of course, concerns about harmful effects of sun rays causing skin cancers. So those kind of effects are more prevalent when we are exposed to longer periods of sunlight after 12 in the noon. So I would suggest the best time would be between 10 and 12 without a sunscreen. Problems like kidney and liver diseases, for obvious reasons, also affect the availability of vitamin D and activation of vitamin D. Certain medications like anti-epileptic medications also have uh, effect and absorption, decrease the absorption of vitamin D from the gut. Uh, Now, treatment of rickets, where children present with bent bones, is of two types, not two types, in two stages. One is replenishing the vitamin D stores in the body. So we check for the vitamin D levels in the blood, and depending on the levels, we replenish. We give supplements to restore the stores of vitamin D. In children who are very young, and the deformity is mild to moderate, replenishing the stores itself is enough for the bones. As they grow, they tend to remodel, and then the deformities tend to get better. In children who are closer to their maturity, who are older kids, and they don't have enough time from the diagnosis to the bony maturity, or in children who have very severe deformities. Now, there is something known as a growth modulation in children. So, if you imagine straightening a bent or a curved bone, it has to be broken and set right. It has to be cut and set right and fixed. Now, this is true for adults, but in children, since they are growing, what we can do is use the growth to direct the growth in a particular direction. So when the bone is bent, we will arrest the growth in one particular direction, encourage the growth in the other direction, so that the deformed bones get straightened. The advantage of this kind of treatment is, one, it is a much smaller surgery. It has a very short recovery time. You don't have to break the bones. The child will be up and about and running in 3 to 4 days. The pain is much lesser as compared to straightening the bones by cutting them. So that this is known as growth modulation. So this is used to straighten the bent bones. Fractures in children are very common, and we see fractures on almost a day-to-day basis. Children are very active; they love playing sports, they love jumping, running, climbing things, and they like exploring. So that's one reason why fractures in children are uh, quite common. Now, before I tell you the kind of fractures in children, what is the difference between an adult bone and a bone in a child? The bones in children are much more elastic. They're elastic, as not softer but elastic as compared to that of a adult. Now imagine a dry stick. When you hold a dry stick and bend it, it just breaks. It snaps into two. But imagine a stem which is green, which is wet stem. So if you break it, it breaks incompletely. So it breaks. Sometimes it just bends and doesn't break. So children's bone are somewhat similar to this. They sometimes just bend. They don't break, they just bend. That's called a plastic deformation. And again, this is something which we see only in children. An incomplete fracture where part of the bone breaks and part of it remains intact. Again, this is called a green stick fracture because it behaves very similar to a green stick, a green stem, which breaks from one part and remains intact in the other part. So plastic deformation and green stick fractures are very common in children. These are not seen in adults. Adults, when subjected to a force, deforming force, they just break. Of course, when the force keeps continuing even after they are deformed, complete fracture is also seen in children. Uh, Now, coming to the treatment part, the fact that the children's bones are growing, they have a tremendous remodeling potential. That means they need not be perfectly aligned, they have to be reasonably aligned. And because they have to be reasonably aligned, a lot of children's fractures don't need a surgical intervention. Even if certain bones, if they're aligned like that, in, instead of being aligned end to end, if they're aligned like that, they tend to heal. Not only they tend to heal, they tend to completely remodel. They appear completely normal in a couple of years with no difference compared to the other side. So that again is seen only in children. This remodeling again depends on how young the child is. The younger the child, the more the remodeling potential. So that is one reason why not all children's fractures are subjected to surgical fixation. A lot of them are treated just by plasters and observation, and they tend to heal very fast. And over the course of time, minor malalignments tend to heal very well. That is a good part of pediatric fractures. The bad part of pediatric fractures is the children's bones have an area of growth called as a growth plate. In medical terms, it's called as a physis. So this is the growing part of the bone. If a injury or a fracture happens close to or at the physis, at the growing end, then there's a possibility that the growth is affected. If part of the growth plate is affected, it causes partial arrest of the growth, thus causing angular deformities. If the complete growth plate is arrested, it causes shortening of the limb, either the upper limb or the lower limb, as the case may be. So, but some fractures in children are not as good at remodeling as other parts. For example, fractures around the elbow, which is one of the most common fractures we see in children. It's called a supracondylar fracture of the humerus, that is the elbow. So when these fractures are displaced, when they break and they are move, the fracture fragments are away from each other. Most of the time we need to realign them to a perfect or near perfect position and subject them to fixation using wires. Why is this important? Is this particular fractures tends to heal, like healing is excellent in children, so healing is not a problem. So they do heal very well, but they heal in a slightly wrong position, and it is called as a cubitus varus. Cubitus varus is a very common problem we see after a malunited elbow fracture or a malunited supracondylar fracture. Uh, some fractures need to be fixed in children because these fractures are notorious fractures. They are tend not to unite and they tend to create a lot of problems as the child keeps growing. So one such fracture is seen in the elbow. It's called the lateral condyle fractures. Another area where such fractures occurs is the hip region. These fractures are not very common, but when they do occur, when we do see them, they need to be fixed so that to avoid any problems in the future. Another fracture occurs in the forearm called as a Montegia fracture. Montegia fracture is not just a fracture, but fracture along with the joint dislocation. So when the fracture happens with the joint dislocation, it needs to be fixed so that the joint comes back in its original position. So these are the things regarding, in short, regarding pediatric injuries and pediatric fractures. Uh, I will move on to the next topic, which is the flat foot, again, which is a very common. Parents come with this problem almost 2 to 3 times a week. Any questions regarding fractures and flat foot, I'll take at the end of the session. Flat foot is a condition where the medial arch, it's called the medial longitudinal arch of the foot, becomes flat. The whole of the foot touches the floor. So again, flat foot itself is not a problem. Some facts about flat foot in children. Flat foot, I should say, is the norm in newly borns. As in children, the arch to appear takes about 7 to 8 years. Some children it does appear earlier, but we should wait till 7 to 8 years for the normal arch to appear. So before that, we should not be worried that the child is having a flat foot. Uh, there are two very common varieties of flat foot. Commonest variety is called the flexible flat foot. Rigid flat foot is an uncommon variety and it almost always requires a treatment. The most common one is the flexible flat foot, regarding which we'll be speaking about today. There are several reasons why there might be a flat foot. One of the most common reasons is a medial flat, the chubby feet of a newborn child or a child who has not yet started walking. That means that area is occupied by a lot of fat. So it's not that the child does not have an arch, but the arch is covered with a pad of fat, which resolves as the child keeps growing. The second reason is hyperflexibility or hypermobility. Again, this is a very common thing which we see in general population and especially children, is the hypermobility of the joints. Hypermobility of the joints just means that the ligaments which are responsible for holding the joints, where the two bones meet, the ligaments which are supposed to be having a certain elasticity are much more elastic than what they're supposed to be, and they tend to uh, give a lot of range of motion to the child. When we so the range of motion is supposed to be that, but in a child with having hypermobility or hyperflexibility, the child is able to move or bend back the fingers a lot. That means the ligaments are much more lax. The same laxity is there in all the joints, and same thing happens in the foot. When the child stands, the arch just collapses down. This again, I should reiterate that it's just a normal variant, and neither hyperlaxity or hypermobility or flat foot in itself is a problem. It's a variant of normal, because a lot of people have hypermobility and hyperlaxity without any consequences in their day-to-day activities, including sports activities. Uh, when do you have to worry about treatment? A practice which used to be a very common thing earlier is modified footwear where we put arches in the foot. We no longer do that because, like I mentioned earlier, arches take time to appear. They appear by 7, 8, up to 8, 10 years sometimes. And the child to start with does not have a problem. Either the grandparent or the father, mother, they notice that there is something not normal with the foot. The arch is not there, the curve is not there. They get worried and they bring the child to the hospital. The child does not have any problem. The child is running, jumping, playing everything, doing sports. So when we introduce this new modified footwear to the child, it becomes very uncomfortable to the child. It doesn't know why this weird kind of footwear is being imposed on the child. So many a times it becomes difficult, and if it is enforced strictly, the child might have start having pain where it was painless to begin with, because child is now uncomfortable. It's not able to adjust to the new footwear where there was no problem. We do give these arches in an older child who starts having symptoms. Typically, the symptoms start anywhere between 9 to, if the symptoms come, they are usually saying anywhere between 9 to 11 years of age. And usually it's a pain. And children who have pain because of flat foot, first they are assessed to make sure that flat foot is the cause of the pain. Children who have pain because of flat foot, again, there are a very small percentage of flat feet children who have flat feet who develop this pain. These children tend to benefit a lot from modified footwear, where and they tend to be more compliant, because the pain goes away once we put the medial arches. The pain goes away, so they are more compliant. They want to wear the footwear because with the footwear they are able to do a lot of normal activities, including running, jumping, and sports. Apart from that, if the child has very severe deformity, again, this is very rare, but if the deformity, the child starts walking on the inner border of the foot, because over time it worsens. So these two cases where child starts having pain or the deformity is very severe, or if the child is having difficulty in wearing a normal footwear because of the shape of the foot, in these three conditions, we insist we start treatment. Uh, an asymptomatic flat foot need not be treated. They can do all activities, including professional level sports. So they are not restricted from doing anything. Uh, Another fact about flat foot is it's very common. 20%. We don't know the exact numbers, but it's estimated that 1 in 5, that means 20% of the population is flat footed. So, flat foot is not a disease or not a problem per se. Flat foot with pain needs to be addressed, otherwise, no. We will go on to a condition called as clubfoot. Now, why I have chosen to speak on this is one, because it is a very common, one of the most common deformities, congenital deformities. That means a deformity which is seen since birth. It is one of the most common deformities, and it is 100% treatable. Um, Many parents, expectant parents, come to me with ultrasound reports saying uh, clubfoot detected, and they're worried that the child will be born with a deformed foot, and what treatment is it, how is the life of the child going to be, whether it is treatable, how, what will happen next. So that this is one of the reasons I wanted to talk about clubfoot. First is one of the most common. The most common variety is idiopathic. Idiopathic means we don't know why the deformity happens, and that is good, because the other varieties of clubfoot are not so good, in the sense they are usually associated with multiple other deformities, like problems in the spine, problems in the hip, problems with heart. So there are multiple deformities, multiple congenital problems, where the problem is isolated, where it is not associated with anything else. Just an isolated clubfoot is something which is common, and it can be 100% treated if the intervention done is the right time and right way. So the treatment is usually begun 1 to 2 weeks after birth, and there's a gradual correction using plasters. So the technique developed by doctor called Ignacio Ponseti, he developed this technique where we serially every week we put plaster and gradually correct the deformity. Uh, Within 4 to 6 weeks, the deformity is fully corrected. Again, the treatment consists of two stages. One is correction phase, which lasts from 4 to 6 weeks. Once it is fully corrected, we put the child on special braces where it's called the maintenance phase. We maintain the foot in a certain position so that to avoid the recurrence of the deformity, and this maintenance goes up to age of 2 to 3 years. With this treatment, the results are excellent. The child can be, the foot can be brought back to normal. The function can be completely normal. So, to remove that anxiety and about and taboo and worry about this club foot, I wanted to mention this. Another problem is the developmental dysplasia of hip. Now, developmental dysplasia of hip is a technical term where the hip joint is not in its socket. The hip joint is away. The head of the femur, so to say, is not inside the acetabulum. This is the technical way of putting it. So what happens is the development of the joint is not very is not adequate. The joint shape along with the ligaments are not able to hold the joint inside its socket. The problem about this is it's a painless condition. So if a child has it, nobody will come to know unless we actively look for it. So that is the reason I chose this topic, because it's a serious problem. But if we detect early, within the first month or within the first couple of months of birth, the treatment is very effective. And the earlier the treatment, the lesser the problems and the more normal the hip can be. Treatment can also be done when detected late, which is usually detected at the age of 1 year. When the child starts walking, that is the time when parents realize that one leg is shorter than the other leg, because this hip is not in its position. So the legs appear shorter, and the child is walking with a limp, an awkward gait. So that is when parents realize that something is wrong. They come, we get an X-ray, and then we realize that yes, the hip is out of it. Usually, when it is detected after 1 year, it requires a surgical correction. So to avoid this, if it is detected early, majority of the hips can be brought back to normal, can be treated without a surgical correction. We just need to put them in a plaster or a brace called as a Pavlik harness, which has a very good results. And also screening test at 4 to 6 weeks of age. Screening test using ultrasound of the hips. So, if you can take away one thing from this is insist on an ultrasound of the hip for your child when it is around 4 to 6 weeks of age as a screening test to exclude any form of developmental dysplasia of the hip. Once you detect at early age, the treatment is very simple and very effective. The older the child is, the treatment becomes more complicated. The results are, with advancing age, the results are much and much less favorable, although it can be done, but earlier the better. So, with this, I will end my talk, and I'll be opening it to questions. I'll be happy to answer questions. Yes. So, I have got a question. I'll read it out. Why children below 14 years develop pain in heel and toes while playing? Play and pain in children. So, pain in children is very common. The challenge is to differentiate it from overexertion, growing pains, and the other side is something serious, where the pain is because of a deficiency or an injury or an infection. All of these are very common in children. So, if the pain is very short lived for a few minutes and it just goes away, you don't have to worry. If the pain is after a lot of exertion, where the child is playing for hours and hours and he has pain in the evening, then you don't have to worry. The other way of detecting if it is a significant enough pain is, one, don't ask the child. So one common thing we parents tend to do is they are worried that there's some problem and they keep on asking. The moment you ask 10 times, the child realizes that this is something which is very important to the parents, and it, no, it knows that if I want an attention, then I have to tell, yes, I have a pain. So don't ask the child if he has pain. Second, if the pain is causing limp, if the child is not able to walk straight, so the child is limping because of pain, that is something which is significant. If the child is not able to sleep peacefully because of pain, even if the child has pain in the evenings, once they sleep, they are able to sleep very well without waking up in the middle of the night. So that means the pain is not as bad and it is just temporary. If this pain is not associated with the swelling or redness or fever, then we don't have to worry. So if we keep these things in mind, we'll be able to, any other kind of pain other than this needs to be brought to the medical professional, to the orthopedic surgeon, and assessed whether it is because of an injury or an infection. I hope this has answered your question. I've got another question. I am 15-year-old. Just a little fall, also my hand gets fractured. Why is it so? How to prevent? What needs to be taken care of? Any issues with my bones? Uh, if again, like I have mentioned earlier in my talk, fractures in children are common because they are generally much more active. They are not as careful as adults. They like to take some risks and adventurous. Children are adventurous, so these are the reasons why fractures are a little more common in children. Fractures a couple of times, we don't have to worry, because a lot of parents are also very anxious. The moment the child has a fracture, they think the bones are weak and they need to pump them up with vitamin D and calcium. This is not the case. Vitamin D needs to be given only if there's a deficiency. And fractures once or twice is not a problem. It happens and it just needs to be treated. Repeated fractures, 3 4 5 times, is something which we need to look into. Again, a 15-year-old having 1 or 2 fractures in his till he's 15 is not a concern. The fractures need to be treated, but I would not be worried about the inherent weakness of the bones. But if they're worried, we can get it checked and have a diagnosis, but usually that's not a concern. Are walkers advisable for strong leg bones in children? Yes, that's a very good question. Walkers, parents want their child to walk as fast as possible. Children start walking around the age of 1 year. Some children start as early as 10 months. Some children start as late as 15 months. Both are normal. Um Children who start walking a little later, who don't start walking by 12, 13 months, can be put on walkers for a short duration of time. But younger children, 7 months, 8 months, it is not advised to use walkers, as their bones are not yet ready to bear that weight. There is a time the bones get ready, the body gets ready to put weight on the bones by the time the child is around 1 year. So putting child in a walker too early is not recommended. And second, they sometimes get used to walking, using walkers for walking. So children who use walkers extensively tend to uh, have delayed independent walking, because it takes time for them to unlearn that no, they can walk without a walker support. So routine use of walkers, no. Uh, in children who walk late, we can use them for a couple of hours a day, but not more than that. Uh, Yes, I've got another question. How to ensure proper calcium diet in children till the age of 1 year? Not only children 1 year, but children of all age groups, including adults, need enough calcium in their routine diet. Now, milk is something children take regularly, and it has a rich source of calcium. So, approximately 500 ml of milk divided in 2 to 3 times a day. And milk can also be given in different forms, like uh, uh, curds, like paneer, and things like that. So, with the normal home-based diet and enough milk, they usually get adequate calcium. And calcium supplement as a routine is not recommended in children of any age group, including children who undergo a fracture. Calcium supplement is not needed unless we document a decrease in calcium in the bloods. Next question: how do we know the content of the required vitamin D in babies is proper or not? Any visible symptoms? Uh, Again, vitamin D is a silent disease unless the vitamin D deficiency is severe and prolonged. We don't see the deformities in children, the bent bones, the pot belly. The vitamin D is also associated with muscle weakness, the decreased tone of muscles. So these are typical symptoms of rickets which are seen when there is a prolonged vitamin D deficiency. So in smaller children, everyday sunlight exposure of 10 to 15 minutes will be good enough. And we don't have to worry in children less than 1 year about vitamin D deficiency. And in older children, we need to get it checked, because there is no way of telling whether the particular child is vitamin D deficient without getting a test done. Waiting for the symptoms to appear is a very late thing. By the time the symptoms appear, already the problem has happened, and we are trying to correct it. And this is no longer a prophylaxis, this is a treatment. So if you want to know beforehand, to establish a baseline, it is good to get it checked, especially if your child is not going out enough in the sunlight to play. Then it is better to get checked and establish a baseline. What are the common visible problems in children which should not be ignored and doctors should be seen immediately? Right. uh, any symptoms which are persistent should not be ignored. Of special mention is fever. If the child is having a joint or a leg pain with fever, that is something which should not be even, you should not even wait for the night, for the morning. If the child has a fever with the leg pain or a leg swelling or a hand pain, a shoulder swelling, that is something which should be immediately addressed and seen by a doctor, because infections in bones and joints in children is another not so uncommon thing which we see at a regular intervals. And consequence of missing infection or delayed diagnosis is can be disastrous. It can lead to sepsis, which is a full-blown infection in the body, or destruction of the joint and causing a lot of growth problems in that particular joint. So infections are something which we should not be not only ignored, we should not be even be delayed by a few hours. Early diagnosis and early treatment is of immense importance. Yeah. Doctor has told flat foot to my kid 1 year old. Does it mandatory surgery? No. A 1 year kid with the flat foot does not require any treatment, not even a footwear modification, not even a arch. Of course, it needs to be assessed to see what is the baseline severity of the flat foot. but we do not do any treatment till the child is 8 to 9 years of age, and treatment is only done if the child is symptomatic or if the severity is very high. Otherwise, the child is essentially normal. Flat foot is not something which should be treated in whoever it is present. So, a routine treatment of flat feet is not recommended. What about the fracture in skull of a child? How much time does it need in take in healing? What kind of intervention does it require? Skull fractures in children is something serious. Like I said, children's bones are elastic. When there's a skull fracture, the concern is not of a fracture itself, because fractures tend to heal fantastic. That's not an issue. It needs to be seen by a neurosurgeon to make sure that there's no damage to the brain. There's no problem inside the skull. So I would not worry about a skull fracture. It heals, and it heals very well. The more important treatment needs to be from an opinion from the neurosurgeon. Yeah. Is walking barefoot good for the child's flat feet correction? Uh, Flat feet tend to foot tends to develop an arch over time, and like I said, most of the correction happens on its own. None of the interventions seem to have any positive or negative effect in the development of flat foot. But having said that, barefoot walking has been shown to have a better feedback, better tactile feedback, and better development. So I would recommend, when the child is within inside the house, encouraging walking barefoot is important, but that does not guarantee a development of the arch, but it is good. It is good for a normal development of the foot. My child is not able to stand after the age of 1.5 years. What could be the cause? 1.5 years, 18 months is definitely upper limit. And if a child has not stood or is not walking with the help of some support, that means we label it as a delayed walking or delayed standing. There can be a lot of causes. It needs to be assessed whether it's just a constitutional delay. Delays can be normal in children who are very premature, born much before their time. But again, I don't want to give a diagnosis, but it definitely should be assessed if your child is not standing at 1.5 years of age. Yeah. Is clubfoot caused because of mother's improper diet during pregnancy? No. Uh, the reason why clubfoot happens, there are a lot of theories, and there is none proven reason why it happens. And mother's diet is not even a theory. It is nowhere even close to what is suspected. So it does not depend on a mother's diet during pregnancy. Like I said, majority, about more than 98 to 99% of them are idiopathic. That means we don't know what's the cause. There are a lot of theories proposed, but at the end, we don't know what is the cause of a clubfoot. So uh, I think those were the questions. Thank you for giving your time and attending. So if I have to summarize, uh, clubfoot is one important thing which every parent is worried about. Clubfoot need not be treated too fast. And second, as one of the questions was, what are the conditions where we should be very quick to act upon, is fever or the child refusing to walk with a swelling where we are suspecting an infection. That has to be quickly uh, assessed and treated for a faster resolution and less complications. With that, I will end this session. Thank you all for the time. Thank you again.